Just briefly as an introduction, if you could first tell us what SCAD is.
So SCAD, short for spontaneous coronary artery dissection, because otherwise saying that over and over again occupies the entire time of the talk. So as you know, this is a less common, it's not rare, condition that presents as a heart attack. So it's a sudden onset condition that presents as a heart attack. In terms of what actually causes it, essentially what happens is, if you think of the heart, and the heart is a muscle pumping blood around the body, it has its own blood supply, which is supplied by the coronary arteries. And the trouble essentially arises within those arteries. So those are tubes, they're taking blood to the heart muscle. But if you think about those tubes as having a thickness, as having a wall around them, I sometimes describe it as like a bicycle tire around the artery as it goes along. What happens in SCAD is within that wall of the artery, you develop a bruise. It's a spontaneous little bleed that happens, and then it expands and forms a bruise, just in the same way as a bruise might form on your shin if you get an injury or a kick on the shin. And as that bruise expands, pressure rises within the bruise, just like if you have on your shin, the bruise can feel tense and tight. Just the same thing is happening in the wall of the artery. And that actually causes the artery to be squashed by the bruise from the outside. And that then means not enough blood gets to the heart muscle, and that causes a heart attack, which is where some of those heart muscle cells die or are, essentially cause pain because they're struggling to get enough blood to keep working. And that's what causes a heart attack in SCAD.
Can you tell us about the SCAD section that's been added?
Yeah, so this is really important progress. So again, many of your patient friends and colleagues will have had an experience where they had their SCAD event, went to hospital, and were presented to some extent with a lot of blank faces or a lot of uncertainty about what this condition is, what you're supposed to do about it. And that's just because if you think about any individual hospital, in a hospital the size of Glenfield where I work, we might see there might be 5 or 6 maybe SCAD cases that will come through in the course of a year. So one doctor is not going to see this condition very often. The result of that is it often gets missed, or the diagnosis is delayed, and it's not recognized immediately. And that can cause obviously delays in terms of patients' treatment care and all the rest of it. So it's really important that we disseminate information about the condition, and that takes all sorts of different things from, giving talks to people, but also these guidelines are very important because they, if you like, are sort of central to what most cardiologists read, know, and work to. So I guess the start of this was the writing of the first set of documents about what the consensus opinions are about SCAD, and that was in 2018. We produced both an American consensus statement and a European position statement. And it's great to see that those documents have had the ripple effect in terms of the impact that for the first time there is now quite a decent sized section on SCAD in these new European Society of Cardiology non-ST elevation myocardial infarction guidelines. So it's recognizing for the first time that SCAD is, first of all, a very important condition to recognize, but also, and this is critically important, that the way it's diagnosed and managed is a bit different from the commoner causes of heart attacks, which is this condition, atherosclerosis, caused by all of the risk factors that we're familiar with, cholesterol, diabetes, high blood pressure, and so on and so forth. So this is a really important step forward, and we hope it will also be reflected by inclusion of SCAD in the ST elevation guidelines when they are updated the next time round. And I think it reflects the fact that Beat SCAD, obviously collaboration with us as the clinical team trying to deliver the SCAD research, and others internationally, that the profile of SCAD has been raised to the point that it's now, if you like, penetrating to that level that the main guidelines now have basically a page on this condition, which is a great step forward.
Are there any other guidelines that you've sort of got your sights on in the next few months or year?
Perhaps the next ones in European terms will be the ST elevation myocardial infarction guidelines. We've been trying to work to at least get some acknowledgement in the NICE guidelines, the UK NICE guidelines, that at least to acknowledge that there are different causes of heart attacks which don't necessarily follow the NICE criterion. I don't know whether we've been successful, but we have submitted a proposal to the review process around those. So we will have to see, but I think it's very important that we keep working to deliver the research, but also to deliver review articles, editorials in the high impact journals that cardiologists and clinicians look at, because that then, it then becomes a fait accompli that this has to be included in the guidelines because it's such an important condition. We believe that, and I think hopefully that will change. I'd like to see it in the, increasingly in the US guidance as well, because those are the main places, the SC and the American guidance produced by the AHA-ACC are the most important things. NICE, I think, would be great as well. One of the important things for the research is that for the position statement, which, if you like, the position and consensus statements, the 2018 documents, the first step on this road, what we need to be able to do maybe 5 years down the line from those documents is to say, okay, we've now learned all of this extra stuff, and so we need to produce a new position statement because things have changed. There's important new information, and that's an important thing. We need to keep saying to people, look, this is changing, we're learning more. Now we need to adapt things and tweak things as we learn about the condition, the best approaches to diagnosing and managing it as we move forward.
Can you give us a bit of a summary of some of the recent papers and collaboration work?
Yeah, so in terms of the work that we've been doing, supported by Beat SCAD, these things take a while to build, but we are, we're making really important steps. So if we start, if you like, at the beginning, the kind of causes, what causes this condition? Is this a genetic condition? Is it inherited in families? Those kind of key questions, if you like, sort of start at the DNA and then work along from there. In 2012, there would have been no understanding of the genetics of the condition. And now we have published the first gene and now genes associated with this condition. So we published the first common variant. These are genes which are common in the population. So if you like, they're more like a risk factor. And we published the first of those last year. And we've just also published another couple of papers looking at both, if you like, rarer gene groups. So those genes that are associated with the Lewis-Dietz syndrome, which is an uncommon cause of arterial diseases. So we're looking to see does that associate with SCAD, and it does in a very small number of people. And then just recently we've published a gene sequencing study, which is some 390 odd of the patients in the study, where we've collected and then sequenced their DNA, and we've done that with support from AstraZeneca to do the sequencing study because it's very expensive. So it's brilliant that they were able to support that part. But we wouldn't have the DNA without Beat SCAD. So the Beat SCAD supported all of those blood tubes and blood taking, and the biobank is supported here in Leicester. So there were lots of little elements that enabled that to happen. And that sequencing study essentially has shown that in terms of those rare genes that are more likely to be causing SCAD, these seem to be uncommon. So about 3.5% of patients have those kind of genes, and they're often genes that we know about from other conditions. So the commonest one is associated with the adult polycystic kidney disease. So it's the adult polycystic kidney disease gene, and then there are others that are associated with the Lewis-Dietz syndrome that I mentioned before, and vascular Ehlers-Danlos, but these are uncommon. So for most people, the condition seems to be more probably due to a number of these common variants, of which we've described the first. So what these important things are doing is they are starting that process. If you think about a disease as starting with the DNA and then going through to affect the cells and then to affect the blood vessels and then ultimately to affect the heart. If you start at the top here with the DNA, it just helps us to start to think about what are the mechanisms, what is actually going on that ends up with somebody having SCAD. And obviously understanding that then gives us potential routes in to be able to impact and influence that risk. So the genetics work is a major step forward. These things are hugely collaborative, and I think it's really important to emphasize the support that we've had from collaborators in France, in the Mayo Clinic, in the US, and Victor Chang Institute in Australia, and also in Vancouver in Michigan now as well, building these things together. So one of the things we're hoping to do is to put all of the genetic information that everybody in the world currently has, including the stuff from our study, together so that we can get extra power from that. The bigger your study, the more easy it is to look at all of these millions of genes, to look at which ones are important. And we're working at the moment on that with all of these partners. And I think it's really important for SCAD research that people are prepared to work together, and sometimes, you know, to step back from leading things. Everybody likes to be the leader, but sometimes, you know, people have to say, okay, you can lead this bit in order for us to make this progress. And so, you know, I think Beat SCAD have been instrumental in allowing us to do this, because, you know, all of these consumables, we can't, you know, materialize them from thin air. So I think that's a really important piece of progress that's been made just in the genetics alone. What we've also published is a number of more clinically focused papers, so looking at how patients do with SCAD, and also diagnostic and mechanistic questions. So we have published a very important paper this year looking at the heart injury after SCAD. And that's, you know, there's a lot of good news in there. In fact, what that shows is that the outcomes in terms of heart injuries, we've always known that the prognosis after SCAD is very good. People do very well after SCAD. But this also shows that, you know, a lot of the heart injuries after SCAD events are very small, and some of them, you know, so small that you can't even see them with the MRI scanner. Now, you know, we have to understand that you know, even if the bulk of patients have small injuries, there are some that have larger injuries, and we need to think and help those people as well. But it helps us to understand what the consequences of SCAD are, and also to think a little bit about the beginning, when you have your heart attack and you have your angiogram. You know, what should we be more proactive in trying to sort of, you know, reopen up the artery? We think that sometimes that's necessary with stents and things, but often if you can leave the artery alone, it will heal by itself, and maybe that's a better strategy. So these data are all informing clinicians about how proactive to be at the beginning, as opposed to being able to sort of take a more sort of observational medical strategy and allow the body to heal itself. And I think what we are learning, what we've learned from that study, is that it's best to be conservative if you can, but that there are actually scenarios where you may need to be more proactive. And those are scenarios where the artery is blocked, maybe in a more important place, where you get particular ECG changes, ST elevation, or rhythm disturbance changes. And these things are coming together with a few other pipeline papers that will inform on this question as well, to help clinicians to make the right choices for SCAD patients when they're at the beginning of the process in the cath lab, when the diagnosis is made with the angiogram. So that's another example, a really good, important example of work that's been done. And also, you know, we have to say that we are not just grateful to Beat SCAD for the funding, but for all of those patients and the healthy volunteers, because we can't work out what's going on with the patients unless we have someone to compare them to. So we have to have these some healthy people as well. So, you know, without those people, we wouldn't be able to be talking about how these papers have advanced our knowledge of the condition. So those are, I guess, a couple of examples. I could perhaps talk for days about some of the other things that we've published and the pipeline things. You know, I know we've produced some, if you like, shorter synopses on specific papers and things like that. But those are just some examples of important steps forward that we've been able to make with the support of Beat SCAD in our understanding both of the sort of why questions, which go back to the genes, and also the what should we do about it questions of the clinician with the patient at the beginning of that SCAD journey.
Does this open up more research pathways to look at treatment for SCAD patients?
So the first thing to say is that knowing how well the heart works is a really important in terms of making decisions about individual patient medications. Our motivation to go on some of those tablets is much stronger if there's a larger injury. But in fact, we found that, as I said, nearly 40% of SCAD survivors, the injury is so tiny that you can't measure it by MRI. And that means that we can be a bit more relaxed about medications for individual patients. It is important to say that at the moment we have no clinical trial data to guide us clearly as to what the best treatments are. And, I think it's fairly evident that that is the next step. The next step is that we need to move into a place of clinical trials. And I think that both the collaboration between international groups, which is very important, and also the setting up of large international registries, and we are working very hard with the European Society of Cardiology on a European registry that, if you like, mimics and models what we've done in the UK. I think those things are critical to that, ultimate aim, because in order for clinical trials to work, what you need is enough people to be recruited to that study. And in order to get enough people, we will need international collaboration to be able to get enough patients who are happy to consent to the clinical studies or a clinical trial, but also of the right type of patients. So there will always be some patients where you can't randomize them to particular treatment because they have to have that treatment. For example, those with bigger infarct, you might not be able to say, oh, I'd like to try them without and see if that's okay, because there's another indication for that medication. So I think that is the future. A combination of the genome-wide association studies and the bigger clinical studies, but also hopefully looking towards bigger observational data sets, and hopefully ultimately towards those randomized clinical trials, which will really answer the questions about which tablets and so on.
How important has the Beat SCAD funding been to your research?
So it's critical. The way that research works in the UK these days, you can't do it on a sort of grace and favour basis. It's not actually permitted. We have to be able to demonstrate that we have resource to be able to do any of this work. So the Beat SCAD resource has been completely critical, essentially. I unfortunately have a day job as a cardiologist, putting in stents and valves and things like that, and so it's not really possible for me to, or wouldn't have been possible for me to have delivered all of the research that we have managed to deliver over the last few years without that resource. To have another person of the quality of Dr. Wood and Dr. Al-Husseini before her, to be able to support this program is completely critical. And I think, also beyond that, as I've mentioned, we've got sort of two key elements to the research, if you like. There's the sort of the why question work, starting with the genes, but then working through, looking at proteins, looking at cells, all of that kind of stuff. We need to have people to do all of those pieces of work. There's the consumables, there's the blood tubes, and then there's people working in the lab to support those things, and all of these things do have a cost. And I think Beat SCAD, all of the efforts, and I see all of the amazing things that people have done to raise funds. All sorts of amazing and imaginative things. And without those things, we wouldn't be talking today about the genetics of SCAD. We wouldn't be talking today about understanding more about how to manage patients up front, some of the conversations we've had about the tablet treatments and things that have, we're getting more ideas, and there's a lot more in the pipeline that will be coming out from the first phase of the SCAD research studies in the next few months as well. And that wouldn't be possible if we can't pay for the scans, pay for the tests, pay for the assays, and pay for the people that do that. And Beat SCAD have been utterly instrumental in that. We're grateful for the support from the British Heart Foundation at the start as well. That should be, got us very much going, but it has been challenging to get more resource from that source, and I think it's only going to be harder for the next little bit because of the impact that the COVID-19 situation has had on charitable funding. And also we've been very strongly supported locally by the NIH Heart Biomedical Research Centre here in Leicester. So those things are important, but without Beat SCAD, we wouldn't be where we are. And I think we have made a really important contribution, and with others internationally, but I think we can be proud of the contribution that we've made, and that's down to Beat SCAD ultimately.
What would you say are your hopes and plans for the future of the research?
I think it's totally brilliant, the fundraising aspect of it, and I'm staggered and amazed by it, and I think also we should thank you and the trustees for the stuff that you do to keep the whole show on the road. It's amazing. Going forward, I think we have a lot of different things going on at the moment. We are progressing the genetics, as I've said. I think we are working very closely with our international partners to deliver this genome-wide association study. We're hoping that we may get 2,500, maybe 3,000 patients' genetics included in that study, which, if you think about, I always remember that the first photo of me and the first group of UK patients that we used as the founding group, and there's sort of a dozen of us in total on that shot. And now we're talking about thousands of people. And I think setting things up in Europe is going to have a big impact. And as I've said, hopefully we can move to clinical trials ultimately. In the shorter term, we are understanding, again, the bigger numbers enables us to try and understand groups within the SCAD community. So Alice is doing some very important work on men with SCAD, understanding whether that's the same, what the differences are. And also they're a really interesting group, perversely, because they don't have female sex hormones, because female sex hormones, as you know, move around cyclically, and that can make some of the mechanistic aspects of understanding SCAD harder, because it's very difficult to get all of your subjects at the same cyclical point if that's varying, whereas obviously in male SCAD that's not so much of an issue, and it may enable us to understand a bit more about those mechanisms without having these other complexities. So I think that will help both in our understanding of our SCAD, male SCAD survivors, but also the bigger picture as well. The other group that we're particularly looking at, or two groups that we're particularly looking at the moment, are those patients with pregnancy-associated SCAD, SCAD in pregnancy or afterwards. And we're putting together a paper again with our international partners, hopefully, on pregnancy and SCAD, so both those patients who have SCAD in pregnancy, but also the question about having a pregnancy after you've had SCAD and what the implications and potential risks and things of that might be. So that's another piece of work that's very much moving through the pipeline. And of course, there's the question about patients with recurrence. Again, we are obviously hugely aware of the fact that recurrence is something that is in lots of minds of people with who've had SCAD. Of course it is. And we want to try and work with patients who've had a recurrence to again try to understand, is there something different about those people, or is there something about their genetics or how their bodies work that can help us to understand what the if you like risk factors are for recurrence, or is again there something that we can potentially influence that might and reduce that risk. So I think, again, going to the sort of theme at the beginning, what we're trying to do is work from the very top, the genetics, through all of those lab things where we're looking at cells, proteins, DNA, RNA, how they all work, to try to understand the mechanisms. Those mechanistic studies may then give us some novel routes. They may show us new things and new pathways that are specific to SCAD that we can influence. But also in the meantime, we build our observational registry. That means we can understand little groups within it and what SCAD means to them. But it also means that we start to build a group, both in terms of the international collaboration from a clinical research perspective, but also the international collaboration in terms of patients with SCAD, to be able to hopefully move forward together, to the holy grail of kind of clinical trials, where we can then say, okay, let's have a look at aspirin. Is it any good? Is it not any good? Let's have a look at beta blockers. Do they make any difference or not really? And try and compare and come up with some, proper data to guide our decision making.